I'm Dr. Alsina from Madrid, Spain, Hospital Universitario La Paz. I'm the chair of the committee in charge of this course, and I'm very happy to present today the obstetric anesthesia topic. First of all, we have to talk about the labor pain pathways. During labor, we have two stages. The first stage is between the complete cervical dilatation, and the nerve roots involved are T10 to L1. These roots gives you a pain called like visceral pain because it's mediated by A delta fevers and C fevers. When the cervical dilatation is complete, we have the fetal descent and the delivery. That's the second stage of labor. It is mediated by the pudendal nerve, involves the roots S2 to S4, you can see here, and the pain there is somatic pain at the perineum. Once we know we have to alleviate that pain, we have to know also what are the characteristics of the drug when we use it during labor. Almost every drug could transfer the placenta except glycopyrrolate, heparin, depolarizing and not depolarizing neuromuscular blocks, and phenylephrine. If you learn those that do not transfer the placenta, it will be easier for the exam. How can we alleviate the pain during labor? Well, we have several ways to do it. The nitrous oxide has a long history on this side, but their use is every time less used because it shows low efficacy. We can use parenteral opioid analgesics, but they cross the placenta, as we say in the slide before, so they can affect the fetus and the labor. So they are contraindicated. But romifentanil, intravenous continuous infusion, can be used for pain relief in those patients that regional anesthesia is contraindicated. The worst part is that there are side effects on the maternal and fetal side, and they need close monitoring by the midwives. So the most efficacy and the most important techniques to alleviate pain is the regional anesthesia. The technical consideration for regional anesthesia blockade during labor are that mother has the lumbar lordosis increase, the epidural space pressure is increased also, the epidural veins are engorged, and mothers are more sensitive to anesthesia, so we have to use less concentration. What are the contraindications for regional anesthesia? The maternal refusal, for sure, the bleeding diathesis, any anatomical abnormality like previous spinal surgery that can complicate the technique, severe hypovolemia, cardiac disease, neurological disease, and sepsis, including the local injection site infection. What we have to check we make a regional anesthesia. Well, we have to stop low molecular weight heparin at a prophylactic dose 12 hours before, at a therapeutic dose 24 hours before. We have to stop intravenous heparin 4 hours. We have to have an INR under 1.5. If we use Humarinics, we can do the technique if they are using aspirin or other non-steroidal anti-inflammatories, but the platelet count, it has to be over 70,000 platelets. This is you can see it in several society agreements. And this is the last one that I've found, the anesthesia analgesia 2021, that they said over 70,000 platelets like the under limits. Also, if the thrombocytopenia is secondary to gestational thrombocytopenia, immune thrombocytopenia, or hypertension disorders, in the absence of other risk factors. How do we do the analgesia with the regional technique? Well, we have to use low concentration of local anesthetic plus lipophilic opioids. Why lipophilic opioids? Because they allow us to reduce the local anesthetic concentration, and they lower also the motor blockade and hypotension. The commonly used drugs during labor are levobupivacaine or bupivacaine at low concentration, 0.06.5 or 0.1.5, ropivacaine, 0.1 or 0.15, fentanyl, 1 to 2 micrograms per milliliter, or sulfentanyl, 0.5 versus 1 micrograms per milliliter in the mixture. What epidural analgesia modes can we find? Well, we can find a continuous epidural infusion that by itself is rarely used today because it does a greater motor blockade, and they still have breakthrough pain. We can use the patient-controlled epidural analgesia that increases patient satisfaction and reduces motor block. And the combination of continuous plus patient control is the standard nowadays, and increase the satisfaction of the mother and the need for clinician interventions. Right now, what we are using in the maternal hospitals, the bigger ones, are the PF. There is the bolus administered by the machine in a control mode. That means that every 45 to 60 minutes, the pump will administer an automated bolus. And with this technique, the spread is more efficient. They decrease the motor block and increase the spontaneous delivery rate. We can also use the CSE, that's in the combined spinal and epidural anesthesia, that has the faster onset of pain relief. And there is also a technique called the dural puncture. That is, we made a hole in the dura with a spinal needle, and then we do the epidural normally, like the regular one. And this makes the more complete relief of pain with less motor blockade. In this slide, you see how to set the program, the PF, the program intermittent epidural bolus pump parameters. As I say, the interval between the bolus administered by the pump will be between 45 to 60 minutes. In my hospital, we use 45 minutes. The volume that we administer is between 5 and 10. It depends on the height of the mother. We usually use between 8 and 10. And there are also a possibility to administer bolus by the clinician or by the mother. So it's PF plus PCA or clinical bolus. The time between the PC dose to the machine bolus is between 10 to 15 minutes. And the pump flow rate, it should be high, between 250 and 500 milliliters per hour because this is demonstrated that the spread and the diffusion is better for a more complete analgesia. If we compare the regular technique, the continuous epidural infusion plus patient infusion with the PF plus patient bolus, we see that there is less opioid and local anesthetic consumption. There is a shorter duration of the second stage of labor, so it's faster, the labor, higher maternal satisfaction, lower clinical intervention, and lower manual bolus. So we are right now using this technique because it's we know, well, we see that it's better for mothers and for the labor. What about cesarean section? Well, when we face cesarean section, we have to know that regional anesthesia I always prefer. So if we had to think on something urgent, we have to do a regional technique very fast, but it's much better for the mother. Since year 2000, we have we use a nice classification to the urgency of the cesarean. We can grade 1 when it's an emergency cesarean with immediate threat to life of the woman of the fetus. It is number 2 if it's urgent, so there is a compromise, but not immediately life-threatening. Number 3, grade 3, is a cesarean that we don't see any maternal or fetal compromise, like I don't know, apposition, cesarean, or I don't know, but not life-threatening. And number 4 is elected cesarean, like a second cesarean or whatever. The main problem with the regional technical anesthesia for cesarean delivery is the hypotension. So we have to avoid the hypotension because the placenta has no autoregulation, and the fall in blood pressure will be fall in the flow to the fetus. So in most of publication, phenylephrine is better than ephedrine because it has better fetal results, and we have to use phenylephrine over ephedrine. We have to use it we use it in a prophylactic infusion and should be start immediately after the technique. So we can maintain during every moment the blood pressure and the heart rate. We see that we are delayed. If we are delayed in the infusion, we have to rise very quick the doses, and the heart rate will drop with the cardiac output. And sometimes we have to mix with atropine or increase with phenylephrine, with ephedrine. So, and we have a rebound effect. So if we use phenylephrine from the very beginning, there are not as much rebounds and not as much bradycardias. Also, now there are several articles that talk about the norepinephrine as an effective alternative to those drugs, but those are under study. We have to do the co-loading while we are doing the vasopressor infusion, and in our hospital and in several hospitals now, what we use is the low-dose combined spinal epidural because we use lower doses and we reduce the incidence of hypotension that is so bad for the baby. What about the general anesthesia? Well, the general anesthesia is only used if there's an extreme urgency, if there are contraindications to neuroaxial block, on patient request, if there is an inadequate neuroaxial block, and several maternal comorbidities like significant cardiac or neurological disease or abnormal placentation that it will be in danger, the mother will be in danger, or will need a replacement of blood. As general characteristics for general anesthesia, is the mother has to lie down with the left uterine displacement, left tilt position to relieve the orthocaval compression. We also have to have the ramp position with the head elevated. The most trained anesthetist of the shift has to attend the mother. We have to use a large bore intravenous access to administration of fluids and phenylephrine. We have to complete monitor the mother, and the airway should include difficult airway trolley, because mothers can be difficult to intubate. We have to pre-oxygenate, and right now we can do it with a very tight fitting face mask with oxygen flow about over 10 liters per minute, or a high flow nasal cannula to maintain a CPAP on the airway. We use intravenous antiacids, primperan and ranitidine, or pantoprazole, and we also use oral sodium citrate, 13 milliliters, right before the induction. We use suxametonium or rocuronium because they are considered a full stomach, and we use rapid sequence induction with Cricut pressure. When we are going to intubate, we have to use smaller endotracheal tubes, guide wire, and there is an increase of bleeding during intubation because the edema on the engorgement of the vessels. There is also increased rate of failed intubation. There is increasing physiological shunt and rapid onset of hypoxia. That's why we have to pre-oxygenate as long as we can. And we have to increase the minute ventilation. And when we face the difficult airway situation, the first part is, as we say, the pre-induction preparation, the oxygen, the pre-oxygenation, and laryngoscopy. After 3 attempts, we have to declare failed intubation, and we have to use a supraglottic airway device. Although we know that it's a full stomach and we can have problems with the bronchoaspiration. That's why in this time it will be very good if we already used sodium citrate and antacid. If this fails to oxygenate the mother, we have to do a surgical access. And this part is proceed with surgery immediately or not. In a cesarean, most of the time it's not a choice. Now I want to talk a little bit about a special obstetric situation. Right now, this is the situation of the cause of death in maternal side in pregnant woman. As you see, the hemorrhage has lowered a lot in the last decades. The hypertension disorder have also decreased. The infection is steady, and right now it could be considered the sepsis like one of the most important causes of death. The pulmonary embolism has decreased also, but not as much as the other causes. The amniotic fluid embolism has decreased also, but it has a high mortality when it happens. The anesthesia complication is dramatic. It has lesser a lot because the regional anesthesia has been very important in this side. The cardiovascular condition has increased as well as other comorbidities because mothers every time are more aged, and the fertilization has increased also, And well, the civilization comes to this. We can have a pregnant woman with transplant, with hepatic transplant, with cardiac transplant, with lung transplant. So this is why the civilization has increased some other cause of death. You have to know the definition for the exam of the hypertension pregnancy disorders. The systolic blood pressure, the preeclampsia is considered when we have a systolic blood pressure over 140 or diastolic over 90 after 20 weeks of gestation, and is always with proteinuria and edema. Eclampsia is considered if we add to the preeclampsia the seizures. And HELP syndrome is considered preeclampsia with hemolysis, elevated liver enzymes, and low platelet count. And this can go to DIC. Severe preeclampsia, it could be considered if we have pulmonary edema, if we have the renal kidney failure, with oliguria and proteinuria over 5 grams. The treatment in the non-severe hypertension is with the oral choice. Right now, the most common drugs used are labetalol, nifedipine, and methyl-dopa. And in a severe hypertension disorder, we have to use the intravenous way. We should monitor invasive arterial, and we have to start labetalol either in bolus or continuous plus bolus. And whenever we are going to place the arterial monitoring, we can use hydralazine in bolus of 5 milligrams. We have to start also magnesium sulfate, 4 grams intravenous load, and then 1 to 3 grams per hour during 24 hours. This is the best way to prevent convulsions. And the definitive treatment of this condition is the delivery. The next complication of the labor is the postpartum hemorrhage. It is considered severe when it's over 1,000 milliliters in 24 hours, and it's massive when it's over 2,500. The etiologies is you have to remember the 4 T's. Tone, atony is 70% of cases. Trauma during the labor. Tissue, retained products of placenta. And thrombin, coagulopathy. The DIC that goes with the, for example, the HELP syndrome. In the management, we have four squares: uterotonic agents, radiological embolization, surgical intervention, and hemostatic drugs. They have to be all considered at the same time. Here you see the figure recommendation in 2022. That is the first part is oxytocin. If oxytocin is not working, we give additional uterotonics. In between, we can start with tranexamic acid, uterine massage always at the same time. And then the last step is other conditions like intrauterine balloon tamponade, Bakri balloon, embolization, surgical intervention, hysterectomy, and also blood transfusion. As uterotonics, we can use oxytocin, that we use it in every labor and every cesarean. And during cesarean, we can use this algorithm, that is 3 units intravenous bolus. 3 minutes after, we consider again the tone of the uterus. If it's inadequate, we administer a second bolus of 3 units. And is adequate, we administer an infusion of 3 units per hour. over 3 minutes, we repeat. And with this kind of protocol, we avoid the hypotension associated with this and the side effects associated with oxytocin. We can also use carbetocin, 100 micrograms, but we can use less, 50 micrograms, and then go to 100 micrograms if not adequate uterine tone. We can add ergometrin to 100 micrograms intramuscular or intravenous. And also we can use misoprostol, rectal or transvaginal. If we have the massive hemorrhage, we have to activate a protocol in our hospital. Yes, you have to go to the ABC, airway, prepare to intubate if it's very severe, relieve the arteriocaval compression, insert intravenous cannula, warm fluids, and immediately require for transfusion. Also, we can administer tranexamic acid and calcium replacement, because you know that transfusion can have hypocalcemia. We have to cross-match 4 units at least, and we have now the point-of-care test that it will have the advantage of a rapid return of the results and discriminate between coagulopathy because of thrombocytopenia or the lack of fibrinogen. So we can start with, we can go goal-directed treatment of the hemorrhage. The surgical interventions that we can find to avoid the hemorrhage is the examination under anesthesia. Is just repair the trauma, uterine packaging, intrauterine balloon, this is the Bakri balloon, Bell-Inch suture, that is this one, uterine and internal iliac artery ligation, and final, the hysterectomy, the obstetric hysterectomy. We can also go to selective embolization in the radiologic area. And right now we have the RIBOA, that is an endovascular balloon that is inserted using ultrasound or fluoroscopy, so we don't need to go with the mother to the radiology area. And we can use it not only to treat, but also as prophylactic before surgery in patients like with placenta accreta. The potential risk of this balloon is the distal organ ischemia. What we do is to inflate, and we have to insert it through a femoral artery. It has the balloon. We have to go with the ultrasound and go as far as we can, leaving the renal arteries, and we fill the balloon so the flow of blood will be less. These are the 3 books that I recommend for the obstetric part, that I also, the same ones that I did for the maternal physiology topic. And this is my hospital, and well, you're welcome there if you want anytime. Well, thank you very much.